So our understanding of these conditions has evolved a lot. And from what used to be considered just all in their head kind of thing, we now actually have an explanation for it. Your brain and your gut are like on a different communication pathway. Your brain's volume's turned all the way up on what it's sensing and feeling in the gut. What we're trying to do is we're trying to change that communication.
Hello, everybody. Welcome back to Off the Charts. Today we are talking to Dr. Rachael Lovink, who I've known for quite some time. We met at Boucher many years ago. How many years ago?
I'm trying to think. I think 10 or 11. Well, no, it would have been like 12, 13 because I graduated about 10 years ago. So yeah, 13, 14 years.
Okay. And like you're very much in the GI, digestion, gut space. And
Yeah.
I follow you on Instagram, and that's how I've been seeing your stuff. And I was like, oh my God, she's saying such wonderful things. And she's saying things that are like really different than what most people are speaking to. And I think you might agree to that. But like,
Yeah.
why are you so into the IBS gut constipation world?
Yeah. I mean, I think like all MDs, we have our journeys, right? And they help inform us in terms of like, I think where we naturally like find interest, but also what I found in my practice is it was an area where I just could offer my patients so much more context and lived experience with it. So I had IBS from a very young age. I actually just made a post about it today because it's a very long story. But yeah, I struggle with it from probably honestly like 8, 9, 10. Like I don't even know. I don't know life without having gut symptoms. And so that was just part of my world. And, you know, my journey spanned many different versions of how that looked. I went through an eating disorder phase. I went through disordered eating phase. I went through trying to fix my gut. I went through all the things. And, you know, even in naturopathic school, we never got taught about what ultimately I learned, which is that I was struggling with a disorder of gut-brain interaction. And that for me was like the biggest turning point in my own healing, but also in my career as a naturopath, was like finally understanding this piece that put it all together. And up until that point, I was like doing what a lot of people do, and honestly, what a lot of like the online space and even like functional, medicine space is. It's like fixing, grasping at like these one root cause idea. And I did that for a very long time. And even in naturopathic school, that's kind of what we get taught. We get taught like, find the dysbiosis or find the overgrowth, treat it, find the food that's causing the issue, eliminate it. And yeah, ultimately like repair the like, but no one taught us, or I certainly don't remember learning. We didn't learn about D2PIs, and we didn't learn about this like broader lens on like how our brain and our gut, our microbiome, and I also include the pelvic floor because of my constipated patients, that's super relevant. But we didn't get taught that lens. And so that's the lens through which I treat all my patients. That's the lens through which I found for me was like this, like, whoa, okay. My like early life experiences, my relationship with food, like it's all connected. It's not separate, right? It's not. And for a long time, I thought it was all these separate things, but it was all one. So that's why I'm so passionate about it, because it's my own lived experience, and the science, the evidence supports it, right? We know, and I know we're going to talk a little bit about this, but like the risk factors with like IBS and DGPIs. And it just really helps to like take that context. And so that's why I'm so passionate about it, because we know how important it is for GI and the chronic GI space for us to be like looking at the broader lens and not just these like rabbit holes that a lot of us end up down.
What makes me wonder why we're not taught this? Why is it not part of our general standard of understanding? Because it is the root for so many people. It is the root, if not for everybody, because we ignore this gut brain. We speak a lot about it, like we pay lip service to gut brain. But why do you think we don't actually make it the forefront of how we speak to ourselves and our patients?
I think because the science has evolved a lot over the years. Like I remember, I mean, even I've speaking to some of my MD friends about it, and they say, we didn't get to talk about this. This wasn't part of the conversation even like 8 years ago. So our understanding of these conditions has evolved a lot. And from what used to be considered like maybe like just all in their head kind of thing. And we thought that like a patient who had like anxiety and like was like talking about these symptoms that like when we did a colonoscopy, nothing came back normal was like crazy. We now actually have an explanation for it. And so the science has like, and we know that like when we learn things in like the evidence of science, it's really slow to be adopted into like practice, as, you know, I'd say maybe even especially in conventional care. But like, because our understanding of it has evolved so much. And so I don't think it's at the forefront because it's also not in the medical training system. Like, you know, most doctors are not, and certainly not 10 years ago, were not being taught about these things. And like I just explained, I was not taught about them even in naturopathic school. There are changes being made to like the curriculum in terms of like what conventional doctors, and I actually don't even know if in ND school they're being taught about these yet. I'd love to know.
No,
Um,
no, don't even ask. There's a bunch of drama happening with all the schools, so
oh, okay.
hope they
Yeah. I mean, I'm scared to ask. Yeah. So it's not taught. And so unless you are, you know, I mean, I know most doctors do continuing education, but I think unless it becomes an area of expertise, you're probably not going to learn a lot about it. And so then, you know, having the conversation feels intimidating. And I think that's also what we see is that for a lot of doctors, when they don't understand it really well, to explain it to your patient is really hard. And I do know a lot of doctors struggle with that, is like, how do I explain this gut connection piece? Like, and they're just like, well, it's the gut brain connection. I don't know. But to have the like words and the like nuance to be able to really help patients understand it, I think you have to have a little bit more. Well, it needs to be taught and you have to have the experience with it.
do you think, here's my theory, that one, it's a predominantly female
Yeah.
concern.
Yeah.
So that's already a
Yeah.
X against getting attention for this
Totally.
problem. Two, um, we're, for the longest time, gut stuff has been, I mean, pardon the pun, but like poo-pooed because it's like
Mm-hmm.
a lot of, oh, it's a diagnosis of exclusion, like, that makes even the, like, framing of that in medicine of being like,
Mm-hmm.
"Okay, you don't have Crohn's disease, you don't have colitis, you don't have a like, an infection." So, it's this leftover like, this
Yeah.
is leftover garbage thing over there that you're just like, "Okay, now cool, like, now you're gonna have to deal with it with the ways that it works for you to deal with it." And
Yeah.
then the third, I think that the most important part, which is why I think you're so interesting, and I can't wait to hear your experience, but it's so hard,
Mm-hmm.
I think, to, like, dive into that, like, the gut brain, nervous system, hypersensitivity, stress response,
Mm-hmm.
like, that's so hard.
Yeah. It is.
Harder than getting a shot, taking a pill, trying a different diet. You know, like, what I mean? Like,
Yeah.
isn't it?
It is. It is. And I think it's like one of those things where I almost think that every patient kind of needs to like go on the journey of like trying the quick fixes of like, okay, let's just see if a probiotic works, or let's just see if like, you know, if I treat SIBO 5 times, if it works. Because in some ways that's like easier because it's like there's this end. It's like an end. We just take the rifaximin for 4 weeks and then we're done. And then, okay, my life, I can go move on with my life. And I almost think it's like a rite of passage for patients to do
Right.
that, to then realize, well, frick, like I'm still not better. So that's often where I meet patients, is at that end of that, like some, you know, 2 year, but often 10, sometimes even 20-year journey. And I mean, my goal is to like meet people earlier on the journey so they don't have to waste so much time and energy and mental health in that journey. But yeah, I think you're right. It is hard because it's not something that we just like treat with like HRT, or we just like, you know, it's like so much more nuanced and complex than that. And for a lot of there are limitations on people, like, you know, because of the coexistence of like mental health disorders in patients who have IBS and other DGBIs. Like, it means that often there's like a capacity too, in terms of like they're already feeling stressed in their life, they already are like anxious, they're already like, and so then to say, well, now we also have to have you rebuild your daily routines and all that, it's like sometimes that's a limiting factor. But it is the work that I think for most patients is what allows them to find a path forward that's sustainable, and a path forward where they're not constantly like wasting money and time and energy on things that don't work, and that really allows them to feel like they're back in the driver's seat. So that's a harder conversation to have.
Do you
Um,
feel like you have to have this like really front loaded conversation with people because you know the perspective you're coming from, right? Like you're just like, I know where the problem is. So like you're like, okay.
yeah.
And the person's like, but like I want the antibiotic that my girlfriend took, or I want the special diet that my dad did. Like, do you find when you're introducing all of this to a human being sitting in front of you, and you're just like, okay, how much time am I gonna have to spend with them in this in this dialogue to get them to understand like where should we be going versus,
Mhm.
you know what? Sure, let's explore the thing that you thought might be the thing that you just need guidance from me, like a pill.
Yeah. I mean, most patients have already done that by the time they see me, but that you bring up a really good point, which is that like education and assurance and validation is like at the top of the algorithm. And it's even there in the evidence at the top of all the algorithms for all the DGBIs. It's like educate your patient, make sure they feel validated, make sure you assure them there's nothing more serious going on. Because when we do that, our patients feel like, okay, my doctor, I trust them. They also feel less worried. There's something else they need to chase. And so I think there is this really important role for us, and especially as NDs, because we have more time with our patients, like, and we're usually able to have those more like, I would say like nuanced conversations, but that is so important for exactly that reason, because front loading it with like the education component and really helping them understand and also validating, right? I think a lot of patients come to us feeling really dismissed by their doctors and really sometimes also worried that there is something their doctors are missing because they feel dismissed. And so the trust, the like education, the like top of the algorithm, the like, is so important for that exact reason. And so, yes, I do front load it. A lot of that can shows up in my social media. So sometimes before patients even see me, they've been following me for months or, however long. And so they do know that's part of the conversation. But I am actually learning how much more time I actually need to allot to that. And that's actually a learning process I'm kind of like just evolving with, is that we need so much more education. And that might even look different over the next years, because what I'm realizing is, like, I'm sure all NDs or doctors who specialize or have a focus on something, is that like the amount of things we repeat, like I repeat myself so much, so much, so much. And so I'm
Yes.
like, okay, I think maybe there needs to be like a bigger educational component that patients do as a group. So anyways, it's a bit of a tangent, but yes, the
Yeah.
like front
That is
loading is so important.
that's so helpful because as a clinician who like really wants to give the person help,
Mm-hmm.
I also get stuck in the, well, what if I just gave you this lovely little pill? So,
Mm-hmm. I
and then,
know.
you know what I mean? Like, it's like the person's in so much pain. So I'll be like, okay, have you ever considered an antidepressant that helps with visceral hypersensitivity?
Yeah.
And that maybe that helps us for some time. And then this is what happens, Rachel.
Yeah.
They're like, oh my God. That is so much better. Did it solve their problem? No. They're on a
Yeah.
pain reliever because they have a
Yeah.
pain condition. And then
Yeah.
they're just like, "Thanks." Like,
See you
did you
later.
did you see girl, did you do the cognitive behavioral therapy that I asked you to do? Did you, access
Yeah.
this, that, and the other? And they're just like, "Well, I don't know if I need to do
Need
that
to.
anymore because I'm in
Yeah.
less pain."
Yeah, I mean, you bring up a really good point, and I do think there's like so many things to speak to there. I think like I try not to offer those kinds of solutions until I feel like my patients understand, and not that I'm withholding things. I also think that yeah, we need to meet our patients where they are, and if they're coming in like in a really distressed state and their symptoms are having a really big impact on their quality of life, we do actually owe it to them to like give them some immediate relief. So I don't think what you're doing is wrong. I think that's
Mhm.
actually a really good approach. And it's like, how do we also help them understand the bigger picture? And I think some patients will be interested in that journey and some won't. And I don't think we're going to change the minds of patients who aren't. But I think like at least if we have the conversation in the first visit that like this is a bigger piece, and
Mhm.
maybe helping them to bridge together like how it's showing up in different areas of their life, because they might be experiencing it as abdominal pain, but we know that in people who have IBS, for example, that it's probably also showing up in anxiety and also maybe showing up in their relationship with food, and it's maybe also showing up in their fatigue. And so if we can help them to see the bigger picture and how these conditions, because they don't just affect the gut often, we might inspire our patients to like do some of the more foundational things that move them in the right direction. But I will say that I do 100%. Like, so I have the first visit, we talk about like the big understanding. I go actually right into treating symptoms first because that relief piece is actually really important for people who've been struggling for a long time. So I think what you're doing is really great. I think we also need to like help them connect the dots too.
I think I'm not great at connecting the dots because, and that's why I find you so interesting and what you're doing online so interesting because I don't know, honestly, I don't know how to connect the dots. And I was like, okay,
Hmm.
I can't wait to talk to her
Hmm. Yeah.
because I'm so in, I feel like I'm in this, like, okay, so like how you said, medicine is over here, gut
Yeah.
brain connection, symptomatic management, and like helping the person and maybe asking them to do specific kinds of ways of eating. And then I'll say, go out there and find somebody who's going to help you with the collecting because I don't know. And that's why,
Yeah.
and also because of those reasons, like, oh, this is actually a lot. I'd have to like really become this as a provider in order for me to do justice to it. And I think that's
Yeah.
what you've done. You've become it as a provider in order to do justice for it.
Yeah, thanks. Yeah.
Yeah.
Yeah, it is a big passion. And I think you're right. It's not something you can just dabble in. I think, like, there are ways you can support yourself if it is an area of interest. But I think the symptom relief is a really important piece. And I don't want to downplay that. Like, I think we can have an idealistic vision that we want our patients to really understand the condition and to like treat the true root cause and underline. But ultimately, our patients just want to feel better.
Mm.
And so I think if like we offer them a neuromodulator, which is what you're talking about, the antidepressant, low dose antidepressant, we call them neuromodulators in the GI space because it helps to remove the stigma from it. But if we use those and it helps our patients feel better, great. At some point, they might come back to you because they're like, oh, but I still have these other symptoms. And then we can connect the dots. So the journey might be longer. I think in an ideal world, I love the idea of just like doing it all together. But patients all have their own journeys. I'm sure you've seen that in many other areas.
Absolutely. The reframing of medications and reframing of agents is so important too,
Yeah.
because there's so much attached to like me saying, oh, I'm going to prescribe you, let's discuss an antidepressant. They're like, whoa. And then I have to spend minutes to be like,
Yeah,
okay,
yeah,
listen, let's talk about like off label, let's talk about labels, let's talk about all of
yeah,
that. And then just know that not everything belongs in a silo of sort of like judgment because
totally.
you have a bias against certain things. And like, and so I think that's so important. I actually have never heard calling those neuromodulators. That makes
Yeah.
so
I
much
don't
sense.
even use the word antidepressant because of that exact reason. And they coach you on, like, I mean, I've done lots of training through the Rome Foundation, and you're encouraged not to use the term antidepressant. Like, sure, when you then explain it, you can say it's a low dose antidepressant. And of course, when you say SSRI, they're like, I know what that is. But like, I use it front, I'm like, it's a neuromodulator. And when you connect that to the gut brain, and I actually explain it as like, we're using this as a tool to help turn down the volume in the gut. Your brain and your gut are like on a different communication pathway. Your brain's like the volume's turned all the way up on what's it's like sensing and feeling in the gut. What we're trying to do is we're trying to change that communication. And that's what neuromodulators can help us to do. There's lots of other things that help to change visceral hypersensitivity and turn the volume down. But neuromodulators, especially for patients who have very high visceral hypersensitivity, which we can assess using like a VSI questionnaire. But like when that's there, sometimes they need that actually as a front loaded tool. So I think like, but yes, the stigma around it is so important to change. And I think when patients come to us as NDs, they're not really expecting us to like prescribe a antidepressant or just prescribe laxatives, which is another area that like I see a lot of the stigma. Um, but I think it's a really important conversation to have. And I think it actually holds a lot more weight when, as NDs, we can have that conversation with them about medications. And I think it also gives it, we also probably will get more trust from our patients because they're not expecting it as an ND who's like treating the whole person and treating the root cause to be talking about medications. And so when we do, and we can help them to see the role it plays, I think it probably actually holds a little bit more weight. But we can't forget to have that conversation. I think that's an
Why
important piece.
why are people's volumes turned up?
Yeah, because of the visceral hypersensitivity. So it's that whole gut brain communication piece. It can happen for a number of different reasons. So, what you're talking about is what we call visceral hypersensitivity. What people need to remember is that, like the nerves, so our gut and brain are connected. Our gut has a nervous system. We call it the enteric nervous system. And that those nerves essentially can be changed from a number of different things. So, genetics, infection, antibiotic use, early life trauma, like really chronic stress. There's lots of things that can essentially disrupt the communication between the brain and the gut. And a hallmark of IBS is the visceral hypersensitivity component, which is where the nerves, you can think of like nerves lining the whole gut, are responding to normal digestive stimuli and processes. So when a normal person goes and eats something, it moves into the GI tract, into the stomach, small intestine, large intestine, and a number of things happen, right? Your stomach contracts, things move, there's like gases that are produced which can cause like distension of the like walls of the intestinal tract. Most of those things our brain in a normal individual do not perceive. It happens below the conscious awareness. In someone who has IBS or functional dyspepsia, that is, they're aware of all of that. And so the threshold for which our brain can sense things in a person who has visceral hypersensitivity is much lower. And so I describe it as the volume turned up, the threshold is low. So normal foods that produce, like, our bacteria will like ferment and break down, usually like things like broccoli and cauliflower, produce gas. That's a totally normal process. But in people who have IBS, because that gas is being produced and it's like distending the walls in the intestine, they're noticing that. And it's like, whoa. And the brain's like, alarm bells going off. That's pain. That's not right. And so that's what visceral hypersensitivity is.
Does somebody who has that have specific things that you look for that might be clues as to why that person might have that? Like, is there a screening that you do that you're just like, oh, okay, that's maybe when this started, or how this started, or is that no longer important because it's already happened?
Are you talking about risk factors?
Yes.
Yeah, it's a really good question. I've thought about this many times. Why does it matter? Why does it matter? It's in the past. We can't change it, right? We can't change that someone experienced sexual abuse when they were 6 years old. We can't change that they had a GI infection when they went to Mexico. You're right. We can't change that. But what I think it really offers people is context to their experience. And like as a clinician, it helps me to like paint the picture of like, okay, this is all lining up. It makes sense, you know? And so you can create the story in addition to the objective information, which we also need, and the ruling of things out, right? We always have to do that, rule the things out, gather the history, and then we can tell the patient a story. We can say, okay, like there's nothing more serious going on. We've ruled it out. But here's what I think happened. And you can tell them that story. You can say, sounds like you had some early abuse, or maybe you went through a really stressful period of your life, or maybe, because you can have all these things too. You went to Mexico, you got really sick, and nothing was ever the same since then. And I think that offering patients that context not only, I think gives them a bit of relief and being like, oh yeah, okay, this is making sense now. And therefore stops them from like pursuing the rabbit holes that a lot of patients end up down. But I think also it allows them to like land in the diagnosis, which is really important. And I talk about this a lot, is like one of the biggest turning points for a lot of people is when they actually land in the diagnosis. I think for a lot of patients, they don't want to believe they have IBS, or they've been told it's just a diagnosis of exclusion, which you talked about. It's not. We're now teaching clinicians to diagnose it through a positive diagnostic strategy, which means like we're not saying we've ruled everything out, therefore you have IBS. We're saying we've ruled everything out. And you have this history that tells us a lot about your story. And here's why you have IBS. And so it changes the conversation so that patients then believe the diagnosis and are a lot more likely to move forward with the things they know they need to be done to treat them properly.
Is there, God, I love this conversation so much.
Yeah.
Okay, is there, I actually feel like I'm talking to you as a student.
No, do it. I love it. We can do that. We can play role play.
But as a student of this. So, do you need to, in your experience, because like I just read this incredible review on endometriosis and its intersection with IBS,
Yeah.
and how they
Yeah.
both have childhood trauma that
Yeah.
happen more often in both of those, and then result in whatever changes happen in the body
Yeah.
uh, because of that stress, that trauma that became in this person endometriosis, and in that same body, they now have a visceral hypersensitivity that looks like irritable bowel syndrome, and they have chronic pain with their gut, and they're so related.
Yeah.
And then you're just like, you read this review, and you're just like, oh wow, like what do I do with that?
I
What
know.
do,
Mind blown.
you
Yeah.
feel you have to? Do you feel like you at some point in the journey with the patient have to address that, or just bringing it up so they land in the that's what I loved. I love how you said they land in the diagnosis. I've never heard that before either. Of And then you can not forget about it, but like that was the part of the journey that got them to land, and then you can be like, okay, that's what it was useful for. Or do you have to go back to that?
The stuff in the past.
Yeah.
No, I mean, I think ultimately, like, do patients need to deal with their trauma? I don't know. That's probably not a question I should answer, but I certainly do refer out. I often refer to like counselors, therapists to help in that piece because there's often some things that come up around that. And I think, like, do you need to heal all your childhood trauma? I mean, I don't know. I just know that, like, when we're working with the GI stuff, there's often like a mental health component that we also treat alongside it.
Mhm.
Um, so yeah, we don't necessarily go back to it. And like you said, we can't change the fact that you had a GI infection. We can't change your genetics. We can't change like what happened when you were young, but we can offer you context, and we can offer, and I think allow you to have compassion for yourself, and then, refer out to get some support in that area. The piece you talked about around endometriosis is really interesting. There's a lot of conditions that are connected to IBS through that visceral hypersensitivity, probably even histamine driven piece, and probably also like the childhood trauma. I actually just recently came across a new term, which I was not familiar with, called neuroplastic disorders. Have you ever heard of it? Okay,
Uh,
look it
No.
up. It's kind of one of these emerging terms, well, at least emerging in my world. And
Right.
I'm wondering if it, like, kind of like the way that disorders of gut brain interaction was like this emerging term, and how neurogastroenterology is like an emerging term. Neuroplastic disorders are like where trauma, nervous system, where, because trauma impacts your nervous system, um, changes how the brain's interpreting pain. So things that are under that neuroplastic um, umbrella are like chronic migraines, fibromyalgia, interstitial cystitis, endometriosis, IBS, like, because it's all related to how the brain is perceiving threat and ultimately pain in the body. And so IBS and endometriosis are very much connected. And I see it a lot in my IBS-C patients. Not always, but certainly it's very connected. And it's, I wonder, this is where the curiosity and, like, I don't know where we are in the evidence around this, but I wonder if they are really just the same condition, kind of, I think what you were getting at, just manifesting in different parts of the body.
That's what I think. I think
Yeah.
like I think there every condition you just said, they are so often found together.
Yeah.
And almost like where there's smoke, there's fire. I have, over the last few years, now incorporated that into my screening, where
Yeah.
if
Me
a
too.
woman comes in with painful periods,
Yeah.
and I'll ask, do you have, and then I'll go through a symptom list of what
Yeah.
would be considered IBS, like
Yeah.
persistent bloating, pain, changes with bowel frequency, changes with bowel consistency, for a long period of time, more than three
Hmm.
to six. And do you know how many times
I know it's
there?
positive, positive. Yeah.
Oh my god! And then so originally a few years ago, I was like, okay, let me just see how connected this is. And then the third thing that also now I incorporate is painful sex. So
Yeah.
it's
Oh,
like
yeah, for sure.
painful sex, what looks like IBS, and what looks like endometriosis. It's like the trifecta
Yeah.
that we really need to screen for, because I think the overlap there will tell us so much information about what's happening with this person, and then really
Yeah.
lead into diagnostics that then we can actually be more confident in how to treat.
Yeah, absolutely. I think, yeah, I mean, is like totally. And I think it's a little bit of a messy picture. Like in that patient who has the pelvic pain, and maybe we've even confirmed endometriosis, like, because that also happens where they've had like laparoscopic surgery. Like, is it IBS or is it an extension of endo or is it the same thing?
Mm.
And I don't know if it matters as much. Like, I think this is where sometimes like giving the diagnosis isn't as important as like what the treatments that we're offering them, and that they're probably sharing some very common underlying mechanisms. And the treatments you're going to offer them are going to treat both anyways. And so that's a bit of a messy territory, I'll totally admit, even with my patients. And I think like where I just share it as like, this is what, our current understanding of it is. Here's like the most likely diagnosis, without labeling them like, with a golden seal. But yeah, it's a messy intersection. I think the research around it is still changing, emerging, and we're learning more.
What do you think are okay? So this is also another thing I really like about how you present your medical information online is you seem because like now this leads me into testing because all
Hmm.
of all these things showing up at the same time, and then you're just like, well, how do I sink my teeth into something? So like a lot of clinicians will be like, well, let me test,
Yeah.
let me do a test.
Yeah.
Tell me how you feel about testing, whether it's like gut testing, breath testing. And I don't mean for other things. I don't mean for like you are highly suspicious of H. pylori. Of course, you're
Yeah,
going to, then you're going to be like, what?
totally.
I mean for a person who has IBS,
Hmm.
what role does testing play with that patient in your practice? And what have you learned? And what message do you have for the world that
Hmm.
really loves to grab and hold on to tests for these people?
Oh, how do I answer that? I mean,
Sorry.
yeah, no, it's a really good question. First of all, just that, like, rule the things out first. Start there. So do your due diligence, make sure the right things have ruled out through like conventional standards. Once we've done that, right, there isn't testing, like even in the functional world, that can diagnose or that can offer certainty that this is IBS. And I think that's where like really getting confident and clear in what IBS is, being able to explain it, understanding the Rome criteria is really important. Functional testing, I mean, I guess the way I look at it is it's, if I'm being totally honest, I think like people tend to rely on it when they don't feel really confident in being able to diagnose it without it. So, and I think we all want to offer our patients like some objective piece that like shows them something that's wrong. It's much harder to sit in the like conversation where we're like explaining things about the gut brain connection and the Rome criteria, and we say we've ruled things out, and to land in that diagnosis with confidence without showing them like a GI map or a SIBO breath test that says something's wrong. That's much harder, and I'll totally admit it's like requires probably some years of experience or just like knowing the right things to say.
Mm.
We do not currently have enough evidence to support the use of like the GI map or like any kind of like, stool test, functional stool test that shows us what bacteria are in your gut. And we don't have any evidence to support what to do with that information. So that's the first thing I'll just tell people is that like it might be cool to know that you have some dysbiosis, and I'm not saying that what those studies or what those stool tests show is wrong, but what I am saying is that we are currently not at a point in the research, the evidence that allows us to interpret that and to make meaningful decisions in how to treat patients around that. We're not there yet. So unless you're ordering that test to just say, hey, cool, you have an overgrowth of lactobacillus and not enough of the bifidobacteria, which just FYI, we know that in any patient who has IBS or any DGBI, there's dysbiosis. We already know that. We didn't need a test to tell us that. We know that when we study enough people and we compare an IBS person to someone who's normal, we know their bacteria is different. We already know that. We don't need a stool test to tell us that. I think where the leaps of faith are being made, or people are trying to like use that information to treat their patients, is by like seeing that on a report and then being like, okay, now we need to use antimicrobials, or oh, now we're going to use like rifaximin. Well, guess what? When we look at the guidelines, we already know that in a patient who's meeting the criteria for IBS-D, that we can just use rifaximin without a test to tell us we need to. So yeah, the functional testing, the GI, the like microbiome tests are not useful. And I think some people argue, well, what about the like fecal calprotectin? You can order that through Life Labs. You don't need a $500 test to do that. And like, I think there's like some of the gliadin. I just don't think the research is there around those pieces. And then around the like SIBO, I think with SIBO, it's a bit of a messier picture, especially I'd say in the IBS-C population, where we're like not sure whether an overgrowth that we see on a breath test is from the backed up stool, like the methane that's being produced from all the stool that's sitting in your colon, or the slowed motility that's changing the interpretation of the results. So it's messy. And so I reserve SIBO testing for once we've worked through the foundational pieces. So if we're not getting progress with like a patient who has IBS-D and we've done the like getting them to eat at regular intervals, we've like maybe tried a low FODMAP diet, again, making sure we're screening them for their relationship with food, because that's a really important piece. But we've done the like foundational things that the guidelines tell us to do, and then we're like still struggling. Then I might say, okay, well, let's maybe look at the SIBO piece. But we don't start there. And I think that's where a lot of people start because they want the test to tell them. Sorry, that's my long-winded answer, and I feel like I didn't even give you all of the pieces I want to touch on.
Oh no, you've given me plenty. I have two comments.
Mm-hmm.
One is the SIBO thing has bulldozed IBS
Oh
so
yeah,
aggressively because a lot of clinicians are relying on this one study from a
yeah,
long time ago that showed
yeah,
that 80% or something to that effect of people with IBS have a positive SIBO breath test.
yeah,
And so then a lot of people say, oh, that must be the origin of IBS. And so
yeah.
if you don't treat the SIBO, which is the most common thing that showed up in this one study through this one measurement tool, then you're missing you're like totally ignoring the cause of IBS.
I just think like that's, if you actually understand what IBS is, you're missing the point entirely. Like it might be a part of it. I'm not saying that SIBO is not a part. It certainly can be because of the altered motility, because of like nervous system dysregulation, because of, especially if they have like a post-infectious and the like immune system is like altered and maybe it's like even damage to the like motility receptors in the small intestine. Sure. But that's just like one component. And if we hang our hats on treating one component, we're missing the point entirely. And also, our patients are going to relapse, which is why I think it happens so often. So, there are risk factors in patients who like might be more like likely to have SIBO, but I think what's happening is that everyone who's showing and presenting with IBS is like being lumped into, oh well, it must be SIBO, and
Mm,
that's
mm.
just not even the case. So there's like, like sure, if a person also is like screens positive for like Ehlers-Danlos and has like, has had radiation or has been on PPI for years, like there might be some risk factors that would point us more towards, yeah, SIBO's probably a part of this piece. But the point I want to make is that, and we can't forget that IBS is so much bigger than that. It's a gut brain disorder. It's not just the microbiota. And if you miss that, your patients will relapse. So I think that's just a really important piece to highlight is like, don't hang your hat on a SIBO treatment to like cure your patients, because it won't. There's so much more at play.
I'm so glad you say that. I've spoken to a few gastroenterologists over the years. One of them said something that I've heard a number of times online, which was probably the moment you diagnose somebody with SIBO, you now have a patient for the rest of your life
Yeah.
because you will be part of the reason why they are now latched onto this diagnosis.
Yes.
And then 6 months later, they're going to reveal that, oh, that was actually an acute treatment symptomatic for them, and
Hmm.
that you didn't
Hmm.
actually get to everything we've just said or you've just said.
Yeah.
And then they'll keep coming back to your practice being like, it's time for me to do that again. Or it's time
Hmm.
for me to do something different because, oh, that was only 80% effective, or et cetera, et cetera. And then you just
Yeah.
end up having this recurrent patient because you told them they have this condition that recurs.
Yeah, totally.
And
Yeah.
and the second was another gastroenterologist who said to me, he was just like, um, yeah, right. He said two things. Um, Bobby, when you tell somebody they have successfully used rifaximin and that great, yay, and you tell them that you killed something, you're actually doing injustice to the fact that rifaximin is also an anti-inflammatory and
Mhm.
also has like pleiotropic effects, other effects on the intestine that have nothing to do with killing
Like
bacteria.
it's a eubiotic. Yeah.
Yes, he was just like, so then how do you know? You can't confirm that the person had SIBO because they got better on rifaximin. That is not, those aren't connected. And then the
No.
second, he was just like, just get them pooing. He
Yeah.
was like,
100%.
get them pooing.
Oh
He was
my
like,
gosh. And
don't need
yes,
that.
so true. I was like in my constipated patients, I'm like, I'm not even considering a SIBO unless there's like a super strong history until we're getting you pooing. Like literally, once we get you pooping, like I don't even actually think I have a patient in the like last few years who maybe in my earlier part of my career, because I'll totally admit in my earlier part of my career, I was on the SIBO train too, which is why I changed. I learned, I did my like, I don't want to call it damage, but I jumped down that rabbit hole too. And eventually I was like, this is not working. My
Yeah.
patients are not getting better long term. And sometimes I'm treating patients 4 or 5 times. Like, is this really what we're doing? Anyway, so, but what I realize is like now, first thing I do is I'm like, let's get you pooping. Let's clear out your bowels because when we get that done, the dysbiosis mostly improves. I bet you the SIBO breath test would be like non-existent anymore. So like, yes, pooping is like that's our like main goal for people who are constipated.
I'm so curious of your experience with this because I very much rely on abdominal x-rays to identify people who
Oh
are
yeah.
constipated because the number, like, I don't know if it's a compliance tool or so I write so many letters because we can't order x-rays here where I am. And so I write so many letters to conventional providers to say, can you please run an abdominal x-ray for fecal loading so I can, one, prove that this is what the problem is. They have a motility issue. And two, then the patient just goes, oh, that is my problem. Oh my God. And then the provider is on board
Yeah,
to
yeah.
like, oh, okay, so this is what we're doing now. How do you do that? Is that useful for you? What do you think?
I don't, but I think this is so interesting. And I'm like, I think like if like it was so easy to do and if I had an x-ray in my clinic and I would 100% do it because I think sometimes it's just really neat to show patients look how much poop you have in your colon. I'm so interested to hear like how are these people and don't know that they're that constipated. I'll admit that I do have some of those patients, and often it's like where we have like a desensitized bowel and it's been there for so long, and it's like they don't almost don't. But I would say most of my patients eat. Okay, first of all, the only time I'm seeing that is when it shows up as an incidental finding when they're like they'll come in and be like, yeah, I was like my doctor investigated me because I was having a lot of abdominal discomfort and pain sometimes, and then they found I was like full of stool. So it shows up in my practice as like incidental findings, which I think is interesting.
Right.
For me, I think I'm so dialed into like how to identify constipation that I think, and I'm not saying you're not, but I think like there's a number of things I look at that I'm like, yeah, this is like the first thing we're gonna like rule out is that it's not constipation that's causing it. Because for most patients, because I will admit, not everyone shows up as their classically constipated patients, which is like they're not pooping like every day, or like maybe it's every 3 days, or maybe even be once a week. Like that, it's like, well, we know you're constipated. We don't need an x-ray to tell us. But I do have a lot of patients who show up with like the alternating pattern,
Mm-hmm.
which is like few days of not pooping and then like 3 days of diarrhea. A lot of the times that is overflow diarrhea, which is like a form of constipation. Or we have the patient who's pooping like small volume. So like they're pooping daily, but it's like when we actually ask them about the volume of their stool, it's like a little bit. So they would never be classically called constipated, but like I can tell you if you're literally pooping a couple like fingers of poop
Mm.
you're eating 3 meals a day, you're constipated.
Uh-huh.
So I don't use the x-ray because I think like when I look at all those things, I'm like pretty confident. Okay, we have a constipation. Or sorry, the last one would be like really smelly gas and bloating that like gets worse throughout the day, which I know most people are like, oh, that's SIBO. But like, and then it's like also small volume poop or like, incomplete. I always just do a clear out protocol because, which I have like, my things I'll rely on. And most patients get better. So I haven't relied on it, but I do think it is a really interesting tool. And I think for, the patient who maybe needs convincing or who wants to see the objective piece of it, I think, yeah, it could be valid.
You definitely talk a lot about gut stuff because you just said it's a really interesting stool.
Did I?
Yeah. Eh,
My
Let
language is just like, yeah. Yeah. I don't even know what I meant to say there.
so when okay, I'll give you an example from yesterday. Okay. Uh,
Yes.
and also the irony that I just got a text from a patient because my patients have my phone number. It's a problem, I know. But like the irony of me getting a text right now saying, "Can I get a re-up of my rifaximin?" The
Oh
irony,
no, really? A
yeah, and,
re-up. I love
yeah,
that.
and then
Oh my gosh.
the patient yesterday. Okay, I'll give this example. This works so well for me in my practice, but for all the reasons I just said. But okay,
Hmm.
a kid. I'm sure the family's gonna be okay that I'm sharing this anon, but the 11-year-old boy, um, not able to go to school, missing lots of school because he's constantly his stomach upset. But
Yeah.
every ultrasounds, everything is totally fine. Doesn't have appendicitis. They're totally fine.
Yeah.
Constantly missing school, and it's full of anxiety, a
Yeah.
lot of anxiety, and they're just like, this is psychiatric.
Yeah.
And this kid needs to be assessed for ADHD. This kid needs to be assessed for all of these other things. And I was like, but you have stomach pain? And he's like, yeah, but
Hmm.
it's not so bad. But like, yeah, so sometimes I do have stomach pain, and then I want to come home, and then I just don't feel well. I'm anxious, and I just don't feel well. So I was like, well, you've gone through this. You've been to the ER 3 times for this weird anxiety, fatigue, terrible
Hmm.
fatigue,
Yeah.
cannot function, wants to sleep all day. I was like, okay, let me um, ask you to get your now pediatrician to do an abdominal x-ray, which had not been done yet. Because they're like, ultrasounds and all those kinds of things didn't show anything. I was like, let's just see if any of this queasiness or any of this pain is maybe constipation. And
Yeah.
that the anxiety is revealing that that's sort of the relationship there, right? And
Yeah.
then the
Yeah.
fatigue, I was like, I wonder what the fatigue is about, but let's see. So then gets a abdominal x-ray and full impaction, lots of fecal loading, moderate to severe.
Wow.
Um, so then they put him on laxatives. None of them are
Yeah.
working. Like 3 months goes by, 6 months go by. Pediatrician does laxative, like
Well,
PEG,
what are they using? I'm so curious. Anyways.
PEG, everyday PEG, 2 capfuls per day. And then um, they were like, this is going to do it. So then I say, so he's not feeling really like much better. So I see, and then I'm like deferring to the pediatrician now because I'm like, you're in charge, you're doing this great. I just asked for the abdominal x-ray.
Hmm.
6 months later, the kid's still missing lots of school, and doesn't really have bowel issues. Like doesn't like goes to the bathroom daily, but isn't able to sort of tell anybody like volume and those kinds of things, right? So the mom would,
Hmm.
he's going to the bathroom. I know he's going to the bathroom, and he's like, he's going to the bathroom. So I said, ask for a repeat abdominal x-ray. Gets a repeat abdominal x-ray. It's the exact same as it was 6 months prior.
No change. Yeah.
Nothing changed, even though
Yeah.
he's taking PEG twice per day. So
Yeah.
I get desperate and I'm like, I really want to put you on a medication called prucalopride, but I'm nervous to prescribe this to you because it's not indicated for your age. And there's a
Yeah.
lot of issues around side effects in people, never mind children.
Hmm.
Take that to somebody. So they go to the ER. He's in a lot of distress again. They go to the ER. And the pediatrician said, no, I'm not putting you on prucalopride. There's no way I'm putting you on prucalopride. That's
Huh.
not a children's drug. ER doc goes, fuck it. Puts him on prucalopride. And now, in the last month of being on prucalopride, after suffering from headaches and like some side effects at the very beginning and being coached to
Yeah.
watch out for depression-like symptoms because it works on neurotransmitters
Yeah.
in the body, his mom said to me yesterday, she's like, he's no longer fatigued. he's going to school he's able to study now every day.
Yeah.
He is pooping differently, but not that dramatically differently. And he has no more pain.
I love this
Like
story. Yeah.
she's like, my kid is 180'd completely.
Yeah.
So
I mean,
I,
I love that.
I needed the x-ray, right? Like I needed the
Yeah.
x-ray to like snowball this whole thing. And I've done
Yeah.
that with so many people who then nobody is now looking at these other problems and like being like, you need a psychiatrist. It's like, oh, you have an observable objective issue here. And that's
Yeah.
why I'm using it.
Yeah, I mean, I think in those, especially in young children who maybe can't communicate to you, like the volume and like some of the nuance that, some of your more older patients, I think that could totally be useful. I also think like, yeah, like I would consider using this, and I haven't had to yet, but like in a patient who's like not responding the way you would expect to like laxatives, or maybe, yeah, maybe where we're not seeing a huge change in their stool volume, but we just need like that extra level of certainty to be like, this is still because there's poop in your colon. I can think of patients who fit into that category. Um, I think for me, what I usually lean on is like the creativity. I use a creativity around my like laxative strategy, which like for some of my constipated patients, we have to get pretty darn creative
Yeah.
in what we're using, the doses we're using. Like I'm pushing people often past like what would typically be, I think, our standard doses. Not like in the medication class, more in the like stimulant laxatives. But yeah, I think it is an interesting piece. I haven't yet relied on it, but I think, for that, like, okay, let's not, because I think maybe in that scenario, you might that like someone else might go to like SIBO, or maybe just
Mm.
abandon the GI tract
Mhm.
entirely, when in fact that was like the golden ticket. And pooping is like, yeah, if you're not pooping, everything's going to feel bad. And I think for the fatigue, the headaches, all those things are things I see so commonly, people who are backed up, and there's not always that awareness piece around their stool volume. And so I think that's where we have to like investigate a bit deeper into the constipation.
I was even surprised. I was like, wait, the kid has energy? And she said,
Yeah.
yeah, his fatigue is gone. And I said, oh my God.
Yeah. Yeah.
It's all,
Pooping.
it's
Getting all
everything.
those toxins out. Yeah. Yeah. It's such a big thing. I mean, I can speak to it personally, but
You kind of hinted this to this a minute ago, and so I'm so curious, but like you said, like which agent was used, and a
mhm,
lot of patients, especially parents, are reluctant to want to use PEG.
mhm.
Where is that role of that agent in your practice? Are you, for lack of
Um,
better, pro PEG or not pro
yeah,
PEG?
perfect. I don't use a lot of PEG, but it depends. So like I find that, so obviously, like for those who don't know, PEG is an osmotic laxative, which means it draws water into the stool. The mechanism can be helpful for people who have dry stool. So we're having like pellety, like, harder stool for sure. That's like the patient who I'm like, yeah, let's use PEG first. Um, and also, especially if like they're really constipated. So if they haven't been pooping for days, that's like the first strategy I use, because we know that when stool sits in the colon longer, what happens is water keeps getting drawn out of it. And that's why it gets so hard, right? It's like that longer time it sits in there, the harder it's going to get. So if we then want to go and start someone on precalibrate right out the gate, or even a stimulant laxative, that's going to cause a lot of discomfort because there's a lot of hard stool. So I often use osmotic strategies in a patient where they're not going very frequently and we need to like soften the stool, or where there's a lot of pellety, like a type 1 type bristle stool. I don't find visceral laxatives often enough for my chronically constipated patients. So I am almost always moving into the like stimulant laxatives first, and then upgrading to like a prescription if the stimulant laxatives don't work. And so, the last thing I want to say about PEG is that in a patient who has pelvic floor problems, so in a patient who has what we call dysenergic defecation, where like the pelvic muscles are not coordinating properly, PEG is going to make them worse. So that's also often a key flag for me, is like, if I'm suspecting there's a pelvic floor component, which in 50% of patients who have chronic constipation, there is. So that's really common. The PEG just makes it worse, because think of it as like if the muscles in the lower part of your colon are not coordinating properly, as in they're not contracting at the right time, or they're not opening fully or relaxing fully, because there's all kinds of sphincters and things down there. The looser the stool is, and imagine that muscle's like not contracting properly, the harder it is for that muscle to work. And if it's already not working, trying to contract around like liquid is like really hard. Versus if you have a more solid stool, the muscles don't have to work as hard. So I find that in my people who have like the dyssynergic, that peg is like almost always a no-go, and will often make their symptoms worse, as in they feel like they're even more incomplete, or they're just like something doesn't feel right. So selecting the right agent really depends on how they're presenting. But stimulant laxatives are really helpful. So I
Mm.
use like things like Senecot, Cleansemore, which is Cleansemore is like a bit of an off-label one. It's not in the guidelines, but it contains, I think it contains senicides, and anyways, a combination of things. And I'll use those in addition to the pegs of the world, to like really get that like clear out effect. But I am often moving patients up into like prucalopride, Constella, depends on like their, like we kind of work through a step-by-step strategy with the laxatives.
I have never heard that double D word you just said. Dyssynergic,
Oh,
uh, dysyner
defecation.
defecation.
Yeah.
What?
I know. I refrain myself from using it because even when I tell patients, they're like, "What?" It's pelvic floor problem. It's essentially where the muscles in the colon. It's a DGBI, so it's one of the 4 subtypes of chronic constipation. So we have IBS-C, functional constipation. Those two exist on a spectrum. We then have slow transit and then dyssynergic. So those are the 4 subtypes. Slow transit is often a little bit of a loner over here by itself. Dyssynergic defecation often coexists with the IBS-C and the functional constipation. So you can have it functional constipation in addition to the dyssynergic. And so essentially what happens is that the muscles in the pelvic, in the pelvic floor muscles are not coordinating properly. So they're not contracting, or the sphincters are not releasing at an appropriate time when you're trying to have a bowel movement. So that often leads to incomplete evacuation. So it's a gut brain problem.
Oh my God. And you said
Yeah.
50-ish%
Yeah.
of people.
Yep.
And
50% or more.
this isn't just squatty potty, right? Like this is more, this
No.
is like pelvic floor physio assessments.
All my patients who are chronically constipated get pelvic floor assessed. Yeah. So yes, and it's a step further than that, because even in a person who doesn't have dyssynergic defecation and they've had chronic constipation for years, they have some pelvic floor problem. There's like no doubt about it, and so they often need that support with like proper positioning, how to actually have a bowel movement without straining. Like, so the pelvic floor component is like almost a non-negotiable with my chronically constipated patients, but the dyssynergic defecation is one step further. And that actually, we actually can't gold standard assess or diagnose it in a pelvic physio appointment, because you actually need manometry to really see it. So it can be missed in a pelvic floor assessment. But the most important thing is that what we offer them for treatment differs. So biofeedback, which is essentially where we stick electrodes to like the base of their pelvic floor and just around their rectum, we attach those there, and then we have them watch a screen, and we have them see how their muscles, when they're bearing down to have a bowel movement or when they're relaxing, what's happening in their with those muscles. And so being able to see it, because for patients who have dyssynergic defecation, what happens is that when they think they're relaxing, because you need your external sphincter to relax when you have a bowel movement, when they think they're relaxing, it's actually only relaxing like this much, when we need them to actually relax this much for things to actually open up and for them to release. And so that biofeedback component really helps them to properly coordinate a bowel movement.
Do all pelvic floor physios, are they all like equal in this way where they're
No.
able to? Oh,
And that's actually one of the biggest barriers that I have found, is like finding a pelvic floor physio who does biofeedback is the most important. And if someone has chronic constipation, they need to be specifically like, so just like people book gut clarity, or gut clarity, meet and greets with like an ND, ask them, do you have experience in working with chronic constipation? So you do need to like do your due diligence, but more importantly, the treatment and the biofeedback is like finding a practitioner who does that.
that is fascinating.
Yeah.
Anybody watching, if you're like in the comments, if you know providers in the pelvic floor physio world, like at them, or if you are one,
Yes.
because it'll be so important to have like a network of people to like, because obviously clearly Dr. Lovink is saying this is a very important part of it. Then, and if there's like this gap of knowing who to connect with us.
Yeah, that'd be great. It's really important. And any ND who's in the GI space and works with chronic constipation, build your referral network. So and I have like people I refer to in my area. And obviously I work throughout BC, but in Victoria and in Vancouver. So that's a really important piece because you want to make sure your patients are getting assessed properly. And this is
Yeah.
not to discredit all pelvic floor physios. I think everyone, just like in the ND world, we all have our niche where our experience level and our like expertise is a little bit better. And so the same thing is in the pelvic floor world.
I think this is okay. We are We're overtime, people, but I'm gonna keep this going for the next 10 minutes because I have
I'm
other things
happy
to
to.
say. So
I love this.
I feel like um this conversation has made this huge, broad, like deep rooted issues condition feel, I mean, again, pardon my pun, but like so much more digestible because
Mhm.
you've like created such like you're looking at things in a very like you're simplifying things for the patient. You're saying like, oh, like you have this, so we're gonna do
Yeah.
this for you. You're not this person, you're that person. So
Yeah.
we're gonna do this for you. Like you haven't blanketed IBS as IBS. You're like, there are so many types of IBS. There's maybe
Yeah.
as many IBSs as there are people. Not to mean like
Yeah.
there's like a 7-8 billion IBSs. It's like, but it's unique for you in the way it's presenting in your body with your history, with your everything and how it shows up with you now. So let's make sure we honor that.
Yeah. 100%.
Yeah.
100%. And I would say also that, like, actually, a lot of patients who don't have IBS will often get labeled with IBS. So, someone who actually has functional constipation or who actually has functional diarrhea often show up in my office with an IBS label. And so, I think because just so we are all clear, like having IBS means you have abdominal pain. A lot of people don't have abdominal pain, even though they have these chronic GI symptoms. So, yes, there are many different subtypes and many different ways in which it shows up in one person, which I think is why sometimes it can feel like a bit of a how do we actually treat this and how do we move forward? And it can feel really overwhelming, I think, for clinicians.
Do you know how many people that come into my office, they say they have IBS because somebody else told them they do, whether it was a clinician, a GI or somebody. And I was like, oh, so tell me your symptoms. And they'll say, oh, I have like looser stools in the morning. And that's it. And I'm
That's
like,
it.
oh,
Yeah.
do you have any pain? No. Do you have any
Yeah.
bloating? No. But
Mhm.
wait, so your only symptom is that you have slightly loose stools in the morning and somebody told you have IBS? They're like, well, what else could it be? I went to them for
Yeah.
this problem. I was like, can you stop having your morning coffee and see what happens?
Totally. I know. I know. Isn't that funny? It's like we forget to like screen the most basic things like
What happened?
or
I was like, just stop having your coffee for the week. For the week, you'll see what
or the
happens.
like, yeah, 800 milligrams of magnesium they're taking the night before, and they're like, I don't know why I have loose stool in the morning. I'm like, okay.
Oh, I had this one woman who she had chronic loose stools, and it was like, this is probably IBS in the GI world. She had CTs, she had ultrasounds, she had a colonoscopy, and a year later, after all of this shenanigans, it was um, her MSM supplement that was causing it as a side effect. And so as
Oh
soon
my
as she took
God.
the MSM, it was like, oh, I don't have my chronic loose stools anymore. She had CTs, colonoscopies, an endoscopy, uh, ultrasounds for a year. It
Yeah,
was
I
her
can't even. Yeah. It's
MSM.
crazy. I mean, I think that's where we can't like forget the really important role we have as NDs in that we get to spend more time with our patients and we get to like ask them about their supplement list and ask them about their medications and help them understand how these things can be having unintended side effects. You might be taking MSM for your like joints or whatever, but that can be having an impact on your bowel. And that's like one of the first things I do with all patients is we go through their supplements and we go through their like medications. And like I double ask on the supplements because patients don't always fill out everything on the intake forms. And often then when I'm like, oh, well, what fiber are you taking a fiber supplement? Because I swear to God, that's like the one thing people are like, oh yeah, I forgot about that. And then it's like they're taking like the oh my gosh, what's that one name? It's like it's inulin.
Um,
And I'm like, it's like an inulin fiber supplement. And I'm like, why on God's name did they make these supplements when the most people who are taking a fiber supplement, someone who has IBS, and inulin is just going to like blow up your gut. So many patients. And I'm like,
it's,
okay.
it's the Metamucil gummy. It's like people live for the Metamucil gummy and it's inulin, and you're just like, and it's just like, I'm
Yeah,
taking fiber. I'm supposed to be taking fiber. If I am taking fiber.
I
Metamucil.
know. And it's so well intended. But yes, I know this is just the mess of like our like health products and how they're targeted at people, and sometimes it's just so misguided. So yeah, I mean that's the first place to start is like don't go down the rabbit holes until you've looked at their supplement list.
It's so
That
interesting
often
because
is.
it's kind of making me like think about something, maybe rethink about something in real time. And it was something I asked you before that I wanted to bring up, which is like GLPs.
Mm-hmm.
So like I've been using GLPs like Ozempic and Zepbound and Manjaro and Wegovy, whatever the brand name is,
Yeah,
for people with IBS because it's been very successful for constipation and pain. And so like there's a study, it's called the Rose O&O that
I
came
looked
out.
at that. Yeah,
Yeah. And it showed that the more GLP you give somebody, the less pain they have within an hour of their injection.
yeah,
Uh, and they can start going to the bathroom better. And the idea is that people with IBS, type C and mixed type, less so for diarrhea, have less GLPs in their blood and have less GLPs in their tissue on biopsy. It's sort of confirmed. And that
mm-hmm.
maybe there's like maybe we're like doing hormone replacement because some people just do not have enough GLPs for whatever reason. And
Yeah,
then that caused this neuroinflammatory visceral hypersensitivity because GLPs reduce pain in the body.
yeah,
Being used for migraines now. They're used for fibromyalgia now. So then I
right,
I read this. I was like, okay, I'm going to start using it when I already saw it. I already saw people who I put it on who happened to have IBS, who I was using it for like weight loss or for diabetes. They're like, oh my confirmed true IBS is better. So I was like, oh my
yeah,
god, let's keep using it. And that it seems to be the best for women with IBS type C for reducing their pain and reducing and increasing their frequency. Because essentially, if you're in less pain, you're more relaxed, and so you can go to the
mm-hmm.
bath. You can
That's
go to
an
the bath.
interesting point. Yeah,
So I've been using it, but now I just have a lot to think about. What
yeah.
how to
I mean,
incorporate something like that into
yeah.
this conversation with a patient.
I guess when you wrote that, I was like, oh, that's interesting. I never would have thought. I mean, I have absolutely seen in my IBS-D patients when we use GLPs, it helps a lot. Like, in fact, I had one patient who it like completely resolved all his symptoms. It was like he no longer had
Mm,
postprandial diarrhea. He was like, because of course it slows, right? But I was interested to hear about the IBS-C piece because I guess in my opinion and my thoughts and my experience with my patients is that in the IBS-C patient, the pain is mostly related to, in how I see it present, the backup of stool. And
mm,
so what I find in my patients is that when we get their bowels moving and we get them pooping regularly and we get them cleared out, not just like a little
mm,
bit of hag, like I'm talking like clear them out, um, their pain goes away. And whether that's because their bowels are more clear and it does take a bit of time. And so what I've like theorized is happening is like as their bowels are moving more regularly and they're cleared out, there's like so many mechanisms that are improving. Like not only do they have that, like think of like, because we know there's that visceral hypersensitivity, and the less stool there is in the colon, the less pressure it's creating, and therefore less like stimulation of that nervous system is happening. But
mm,
also like I wonder, because we're clearing out the stool, we're also changing the microbiota, and like when it moves to a more balanced population, how is that impacting like histamine and like the nervous system and the immune system in the gut? So I think there's a lot of pieces that change as we get the stool moving, and there's less of that also feedback loop between the brain and the gut, because when a person feels a lot of pain and discomfort and backup and bloat and the visceral hypersensitivity, their brain's constantly being like stimulated. And so that communication is just like always firing and they're always aware of what's happening down there. And so
Mm.
my approach has always been to just like address the motility first, and then most times it gets better. But you bring up an interesting point around like how like sometimes the pain is the predominant feature.
Right.
um but then how are we compensating? That would be my question. How do we compensate for the slowing down effect that the GLPs are having on the bowel? What do you do around that piece?
Well, this is the hypothesis.
Mm-hmm.
Through this investigation, like Rose is not a clinically prescribable GLP. It's a studied. It's only for study purposes currently. It's like
Okay.
Eli Lilly like subsidiary, and
Yeah.
we're doing more research around. It's very specifically testing in IBS populations. There's 5 studies so far, and um and it's an acute, like a once a day, so it's not like
Yeah.
the 7-day ones where it's like, oh, we give the shot, the person reports within an hour they have the results are up to 6 times less likely to have pain and
Wow.
constipation than the people who didn't get the GLP.
Yeah.
Um, the odds ratio is up to 6, and the hypothesis is so GLPs slow down our small intestine,
Yeah.
but they increase motility in our large intestine, and that
Okay.
the increase in the large intestinal motility overrides the slowdown. And the reason they slow things down, because we naturally produce these hormones, is to allow for a greater length of time for you to absorb nutrients from your food in your small intestine.
Yeah.
But they do the opposite, like to get things moving there, because you don't want everything to be so slow the whole way. They get
Mhm.
things moving in the large intestine, which is why 20 to 30% of people have diarrhea on GLPs. They're like, I have looser
Right.
stools actually on this. It's like because they're a motility agent actually
Yeah.
in
Yeah.
the biggest motility part of your intestine. And that in the vast majority of people overrides the slowing down in the small intestine. So this,
Fascinating.
yeah,
I think this is where there's probably these subtypes within even an IBS-C, right? Because some probably will respond really well to that and then some won't. But yeah,
it's
I
the
mean, I,
it's the bloaty people up here. I kind of you see me, but like it's the bloaty, it's the very bloated, gastric bloaty people, the people with SIBO, confirmed SIBO, and they know like the SIBO is definitely part of the picture. That's where it's like my kind of like red flags go up. Like, I don't want to slow down your small intestine more when you already have a small intestinal issue.
mhm,
But if you don't have that, that's where I'm like screening and saying, why don't we see? And this is the chicken or the egg thing. Is this a visceral hypersensitivity first? And therefore, if we reduce that neuroinflammatory response there, then they get better with their bowel movements. And maybe in a group of people, it is that, and that you
mhm.
like this hormone to like relax that
Yeah,
connection as well, because we know
I
it
can see
crosses the
that.
blood-brain barrier, et cetera, et cetera. So it's only research so far, but
Yeah,
I'm not a waiter, like I'm not like a
you're an
server.
early adopter.
Like I'm not waiting for 5 years for a guideline to be like, well, what about this? I was like, there's a lot of suffering in this world. Why don't we explore something, of course, with caution, and making sure we're doing right by the patient. So I've started doing that in the last year, 2 years, and it's been working. And that's why I wanted to bring that up with you to be like, are you seeing this? Are you,
Yeah.
yeah.
I mean, especially with the adoption of so many people using GLPs, I think we'll probably see more of that data come out. Um, well, I'm glad you're an early adopter. I'm a little bit shyer in that area, and so I'll probably lean on you to teach me what's happening with your patients. And thank goodness we have people like you, because you're right, like guidelines are slow to adopt changes that are happening in the research. So keeping our eye on what's happening in the research, and translating that into practice is like requires a little bit of bravery.
I don't have abdominal pain. I don't have IBS. But the
Mhm.
one, like yesterday was a very stressful day, and I had some pain, and I told my boyfriend, I was just like, oh, and like my stomach is hurting, and I didn't eat anything, so I think I'm just stressed by something that's happening, and in my brain immediately I think like right as it's happening, I was like, people feel this all the time.
Yeah, I
Oh
know.
my God. No,
Yeah.
no, no, no,
Yeah.
nope.
Yeah. And how our body responds to pain, which is such a fascinating thing, and the vicious loops that happen. So I think that's a piece that you're right around, like treating the pain as a primary component can have these like ripple effects.
I mean, thank you for doing what you're doing. I think it's incredible that you're like so you live this and know this and are clearly doing such wonderful work with your patients, and like I hope this sort of message gets out there because I've I can tell you like I'm not doing enough. Like I can tell you that I'm not doing enough. And so I think there's so much more to learn obviously here. Um Thank you so much, Dr. Rachael Lovink.
Oh, it's been such a pleasure. I really, really appreciate this conversation. And I think that that's what you're saying is not true. You are doing so much. And I think any ND who's feeling that way, we all have our niches where we're really like dialed into. And I think we can all learn from each other. And gosh, I learn from you all the time on your Instagram account. And I mean, your humor and just everything, I think, offers such a beautiful piece for patients too. So thank you.
What a wonderful place to end. So for everybody who's watching, this is Dr. Rachael Lovink. She is in British Columbia. If there's a patient out there who's interested in exploring, which I think you definitely should be over this, we'll write all of her contact information and all of her links attached to this, and we'll collab with her on social media.
Amazing.
Thank you.
Thank you. Yeah. So nice to chat with you.
This is Off the Charts, where great health isn't luck, it's learning. Stay tuned and give me a follow.